Hello, and welcome to the webcast, which is an overview of therapy in people with aphasia. So sometimes when I think about therapy and talk about therapy, I feel like I'm pushing a big boulder up a hill. It's sometimes a difficult task. Therapeutic intervention is actually a very complex neurological and behavioral task. We'd like to make it very simple, and I'm going to refer you back to the idea of critical thinking, right? We want to simplify our thinking. We want it to be one thing or another. We want it to be definable. But really what therapeutic intervention is a series of clinical decisions that are made based on the client's response. So the idea is that the clinician, based on what they know about neurological principles and what they know about behavior, will watch the client's response to a particular stimuli and then provide some kind of consequence to that, which will cause a change in behavior. And so there could be an infinite number of possible choices you could make as a clinician. So part of this then is going to be science. What is the most logical or consequence to provide? Part of it is going to be art. There are going to be some people for whom these decisions are quite easy. They're made quite naturally. They don't even really sometimes know why they made the decision they made, but the decision they made resulted in the patient responding more appropriately. Other people will not have that natural skill, and they will have to learn that skill. Now, over the course of the years that I've worked, I've had a lot of people tell me that they will be able to do better therapy once they have more experience. I don't actually believe that, and that's one of my personal biases. I believe that you become a better therapist because you have experienced that you have linked to thought and critical thinking. If you just are doing it and experiencing it and you're not thinking about why what you did worked or why what you did didn't work, I think you can see 1,000 clients and never get better. Right? Because unless you apply some kind of effort towards understanding what you're doing, you're just gaining more, you're just doing more of the same thing. That does not imply that what you're doing is getting better. Okay? Having said that, there are some people who get better with experience, but there are also some people who never get better with experience. So I think the best chance that a person has at getting better as a therapist is to actually be analyzing and critically thinking about what they're doing. I've been a speech language pathologist for a while now, and every single clinical interaction that I have, I'm trying to apply some kind of critical thinking to. What did I do? Do I think it was effective? What was it that I did that was effective? What was it that I did that wasn't effective? Why did I get the result that I got? And what could I change next time to make this more of a therapeutic interaction, so that every minute that I spend with the patient is productive? And that may be that we're being quiet, because maybe I need to let the neurological system rest. I need to let the neurological system calm. Okay? But I'm doing that in a purposeful way, not because I'm stumbling to figure out what happens next, or because I'm distracted by something in my environment, or because I don't know what to do next, but rather because I've chosen it, such that every single interaction with the patient is as therapeutic as I can possibly make it. I'm not there, right? I've been doing this a long time. I'm not there. I'm not there to 100%, right? But I am always continuously working towards therapeutic improvement. And it's only in that way that we will move this profession forward, by making our patients better. And when people see that our patients are better and are functioning better in their everyday lives, we move this profession forward. So what is therapy? I have this idea that the WHO model helps us to move therapy forward. So the WHO model talks about the idea that disability affects 3 areas. It affects your body function or structure, the activities that you can participate, or the activities that you do, and then how you participate in the world. And some people collapse activity and participation together. I don't necessarily do that. The WHO model also says that disability occurs within a context, that there are environmental factors and personal factors that influence how much your disability is revealed in the world. So I want you to take a minute to think about that. How much your disability is revealed in the world is impacted by environmental factors and personal factors. So we have these concepts of body function and structure, activity and participation. So let me give you some examples. In the case of aphasia, a body function or structure which is affected, you could say would be word finding, right? That's the function that is being affected, your ability to find the words you want to find, okay? So if you write an objective, or your therapeutic intervention is to improve word finding, and you don't think about how that affects activity or participation, then you are simply intervening at the level of body function or structure. And the structures that are affected, of course, would be neurological structures in aphasia. It would be the actual brain tissue that has been damaged. Then the activity would be, right, maybe participating in a simple conversation with a family member. That's the activity. We're having a simple conversation. The participation then becomes, how do I feel at the family reunion? Am I able to have this simple conversation with a family member, with other family members, that allows me to feel included and part of the whole? So those are kind of examples of how you might think about this WHO model and how it drives therapeutic interaction. Our goal, of course, is participation. We might start, some therapists start, attacking the function, the body function, but they should have an eye on what activity that will then improve and how that activity can help the person to be fully participating in their particular life. So I want to talk about some terms that are going to be important in therapy. Process, okay, this is the underlying cognitive linguistic skill that is the problem. Okay, so it's things like word finding, auditory comprehension, syntax, reading comprehension of single sentences, writing at the word level, writing at the sentence level, writing at the paragraph level. It's the underlying part, right? Writing, understanding through comprehension, spoken expression of syntax. The task then is the activity that you do that provides the opportunity for the process to be produced. Okay, so I might give you a task like following one-step commands, and that task then elicits the process of auditory comprehension. Okay, by following one-step commands, you are auditorily comprehending. But then there's this other thing, and that's the therapeutic intervention. It is not the task or the process. It's something else that is occurring within that interaction. So for a therapeutic interaction to occur, there has to be a process that you're addressing, and there has to be a task that you're using to elicit that process, and then there is some kind of therapy applied in there, which is the thrust of what the therapeutic interaction is and what makes the therapeutic interaction, I think, a bit mysterious. There are lots of people out there that I think can engage in the process and the task, but that are not always thinking about what the therapeutic interaction is that is occurring. So one of the things that I like to do is to have people define what they think therapy is, and to define it in a way that doesn't say therapy is therapeutic, therapy is therapy, therapy is helping people, therapy is improvement, right? But that really gets at what is therapy. So I'm going to give you my definition of therapy, okay? And this is how I think about therapy. Therapy is the systematic application of behavioral, learning, and brain-based principles. For example, plasticity, network theory, in a prescribed manner. So in other words, it's not random, it's not trial and error, you're doing it with a purpose. You understand why you are applying a behavioral, a learning, or a brain-based principle. The principles that you're using incorporate the very best external evidence, which is the literature, internal evidence, which is what the patient is doing and what your clinical experience has told you, but specifically how this particular person that you're working with reacts to different stimuli, and the patient and the caregiver preference. And that you combine those things to try to positively impact the impairment, activity, and participation functions in a way that's authentic and meaningful to the individual. So this is my definition. So I challenge you to not look at my definition, but to come up with your own definition that you could use to articulate to someone what therapy really is. So here are some beliefs of mine, and I think I've alluded to this previously. Trial and error is not therapy. So just trying stuff and seeing what people do, that's not therapy. Trial and error is common. I see it a lot when I go out and observe people. I see that they're applying a task to a process, they're seeing what happens, and then they try something, and if it works, great. If it doesn't, then they do it again. They might or might not do the same thing in the next trial. They're just kind of rolling with it, right? They're just doing. It's not really therapeutic. Skilled treatment probes with an application of clinical decision making that's backed by external evidence is not trial and error. I never use trial and error as a description of what I'm doing. I might say that I am doing skilled treatment probes and applying clinical decision making based on the error pattern of the patient. Okay, that's different than trial and error. That says I'm making clinical decisions. I don't believe that drill and practice is therapy. Drill and practice implies that you're going to just have the person practice, right? Practice, 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 practice. That isn't really the application of what we know about learning, right? There are ways to practice. There are times to change the way you practice. There is a certain amount of practice that is applied, and then that practice is changed. So I don't use the term drill and practice, and I know that some authors do. I don't, because I really believe that there are decisions being made about practice in good therapeutic intervention, and that it's not just practice no matter what. I think about my mother trying to teach me the times table when I was a child, right? She sat me down and she just had me do it. If I made a mistake, I just did it more. There was not an adjustment to the practice. There wasn't a practice more, practice less. You don't need to practice this one anymore. You need to move on and come back to this one in a certain time period to determine whether or not you can still do it. Those are the kinds of things that occur in a therapeutic interaction that uses what I would call a high intensive practice approach. Don't do trial and error therapy. There's a potential that that could be harmful to people. So I want to talk about the idea of compensation. Myself and a colleague, Carrie Prentice, wrote a Perspectives article on compensation, and we used this idea from Dixon, Garrett, and Bachman about what compensation is. And they actually wrapped restoration or remediation into compensation by saying that there is some neural compensation that occurs, the automatic reorganization and substitution of functions that occurs without any patient effort. We might think of that as traditional remediation. And they talked about that as being part of the compensatory process, right? And so we kind of took what they talked about from a neurological perspective and applied it to speech and language therapy. So we talked about the idea of these neural compensations and remediation, which is using effort and practice to try to recover a skill, as being part of the compensatory process, but a lot of people would remove that and make it its own separate idea. Substitution of a latent skill is when you're going to use a skill that the person has, okay, and you're going to try to get them to do more of it. An example of that might be a person with aphasia that circumlocutes, and you're actually going to teach them to circumlocute better. So rather than trying to teach them to say the exact word that they can't find, you're actually going to say, you know what, you already do a lot of describing. Let's see if we can get you better at describing to get your point across. That would be an example of substitution of a latent skill. Substitution of a new skill, well, the most common thing that I can think of would be in a person who might be an independent communicator, substituting in some kind of AAC board or system that would help them to be able to get a message across. Accommodation, this is when we take the person and we try to get them to adjust their expectations for how they're going to participate in a way that allows them to participate with the skills they have, so that they have, you know, expectations that fit what their skill level is. So adjusting a person's role in a community group from leading that group to being able to add some comments to the discussion that the group is having is an example of accommodation. And assimilation is adjusting the environment and the expectation of others. So finding ways to change the environment, putting the person in a quieter environment so that they can have better communication interactions and conversations, or helping families to just allow for shorter, less complex utterances so that they're understanding that this is going to be the level of communication and they're accepting and assimilating that. So if we took those compensations as described and we started to build a staircase, we might be able to take the person's ability level and put all of these things in place to help the person get to their desired level of participation. So if we think of AAC as a kind of compensation, we could see it as being a substitutive kind of thing in people who are more independent communicators, but an assimilation kind of thing for those who are going to require partner support and are partner dependent. We're going to get these partners to change the environment and use techniques and skills to help reveal the individual's competency. And we'll talk about that more in the future. So tradition would say that there are three things we can do in therapeutic interventions. We can remediate. In aphasia, we talk about some common principles. There are different kinds of practice that we can use. There is a context to the error that we need to think about. Why did the person make the error? What factors in what was happening influenced that error? What type of error was it? What kind of cue levels are we applying to the individual? How are we fading cues? Can they handle dual sensory processing? Does visual support and auditory support actually have an additive effect for this person, or does it put too much pressure on the neurological system and too much attention is needed to do both, so we need to do one or another? What's the complexity of the tasks that we're asking the person to do, and how do we adjust those, and what are good starting points? So those are some basic principles that might be applied in the remediation in aphasia therapy. In terms of compensation, we have external supports. This could be communication aids that we give to people. It could be some kind of adaptations that we do to the environment. I'm going to throw people in as an external aid. If we change the way people respond to the person who has a communication deficit, then they become a kind of external compensation, a well-trained partner. And then we have internal compensations, things that we're going to try to teach the person to do themselves to help themselves to compensate. And lastly, we have counseling. Education about what's happening is very important to people with aphasia. Referral, finding them other additional sources that can help them. Maybe those are psychological counseling services, or maybe they're other kinds of services. And then guiding the client towards stories and resources that help them cope. Support groups, community resources that are available to them that can actually help them to cope with the feelings and the emotions that they're having around their disability. So finally, I want you to think about, as you're writing about therapy and you're talking about what it is that you're doing in SOAP notes and report writing, I want to suggest some list of some possible words that you could use in that regard. For example, a word like analyze or probe or assess or assist. Using words like that to describe what you're doing with the patient, and I have a whole list here that I've gathered over the years. I'm bridging where the patient is to where the patient is trying to get by controlling stimuli, for example, with the word bridge here. Using these kinds of words rather than I sat with the client and went through pictures, or I showed the patient pictures, or I had the patient follow commands, right? Using words like I presented stimuli at the single command level, and I synthesized the response of the patient and applied additional cues and prompts based on their response. That kind of writing, that kind of skilled writing, is what your employers and your externship sites are going to be looking for. So think about this list as a guide to help you. So that's my overview of therapy. I hope that it's been helpful to you. There is additional resources that I'm going to be providing on therapy in terms of augmentative and alternative communication as a compensatory strategy, and some more in-depth information on remediation practices. Thank you for your time.